people on. Great. So good morning. This is Larry Boris. I'm Executive Director of National Association of Worksite Health Center. We're going to be starting our session now describing the depression counseling program being made available to NAWHC members by Tufts Medical Center. So at this time, I'm going to just go around the table and ask everybody to introduce themselves. So Deborah, why don't you begin?
Thanks, Larry. I'm Deborah Lerner, and I am with Tufts Medical Center, which is an academic teaching hospital in the Boston area, and also with Tufts University. And I am the director of the program on health work and productivity at Tufts, and all of our research and program development has been in the area of worksite health improvement, and particularly mental health.
Thank you, David.
I'm David Adler. I am also at Tufts. I'm a psychiatrist. Deborah and I have worked together for over 20 years on this program.
Great. And we have two participants, and because it's a small group, I'm going to ask you all to introduce yourselves. So, Parajan, I don't have your first name. Would you introduce yourself? And I think it's Kelly Wilhelm. Kelly, would you introduce yourself?
Kelly Wilhelm, Mobile Medical Corporation. Good morning.
And Eunice, would you introduce yourself?
Somebody's on mute.
Take yourself off mute, Eunice. Okay, well, why don't we begin, Deborah, and perhaps we'll have some others join us.
Great, thank you very much. So thanks for joining today. This is a second meeting that we have had with Larry and some of the members, and we'd like to introduce you to a project that we've been talking about that I hope you're interested in. So just to give you an idea of who we are, David and I have developed a program which we call Be Well at Work, and it was specifically developed to improve the care that's provided to working people and at the workplace. And so it is telephonic care primarily. So it's very accessible, it's low cost care and extremely effective. So we are going to be showing you some background on the care model, what is it? And then some specifics about what we're thinking about in terms of a collaborative project with you and others. Through the association. So let me see if I can, I don't know if I could forward the slides. Wait, let me just go back one slide. Can I just go back one slide? Yeah, I think Diane, you have to handle that. No, okay.
Larry is advancing the slides right now.
Oh, Larry has the slide deck. So
Try it now. Yeah, try it now, Deborah.
Larry, just go back one slide if you can.
Okay.
Or maybe if it's on a,
Nope, you're going the other way. Ah, a slide got missed. Okay.
Now this is the first slide.
Okay.
Okay. All right. So I will say that there's a third member of our team. And I don't think, I'm just worried that this isn't the slide deck. Okay.
Yeah.
So it is not the slide deck. Okay. I'll wing it.
Larry, can you just scroll through, because this may be not the original. Just go very quickly down.
No, it's not the slide deck. That's the old one.
This was the brief one you just sent. I'll do. Okay. Why don't you talk? I'll look for another one at this point.
So, you know, the objectives today is to familiarize you with the Be Well at Work program, to present some ideas for a project that we would like to do collaboratively with you, and then talk about the nuts and bolts of it in terms of things like logistics and costs and sponsorship. And so I'll start by telling you a little bit about Be Well at Work. So when we started many years ago thinking about what is right with depression care and what is wrong with depression care. There was a lot that was wrong with it. It has improved over a period of time, but still what we're facing is a situation where there's a sort of a big gap in the depression, there we go, in the care that's provided. So now we can go to the next slide. Okay, thank you. And so one of the big gaps that we all know that depression is probably the most expensive illness for employers, and it's extremely expensive for employees as well. And the major reason it's so expensive is not the cost of the care, it's the cost of functional limitations, the productivity loss that's associated with depression. So there is lots of documentation out there about how costly depression is, both to employers, employees, and also to the quality of life of employees and their families. And the reason is that it interferes with functioning. So you hear a lot about sort of depression as a mood disorder, but what you don't hear as much about is that people with depression have trouble functioning in daily life. And for people who are employed, a lot of that will play out in the workplace on the job. And one of the things that we've learned over the years is that, despite depression, most people want or need to work. They're not ready to give up their job. So what we were sort of dismayed about when we first started working in this field is that when we think about the care that is available through, typically through healthcare providers, insurance companies, and now a whole array of vendors, it's still not really focused on functioning. It's focused on symptoms, so improving mood, dealing with agitation, sleep problems, that sort of thing. All of those things are really important. But the missing piece was, how do we help people who are depressed, most of whom have chronic repetitive depression? How do we get them to function more effectively at work and in life in general? And so through a long series of mostly federally funded research projects, we developed the Be Well at Work program. And so first and foremost, what we had in mind was trying to provide a service in the workplace. And so where we are today is that we've developed what we call a fit for purpose program. It's not a generic one size fits all program. It's a program that's designed for working people who have depression and need help improving their functioning. So what is it? It's evidence-based, which is really important because, as you know, the field of, in general, of wellness and mental health and well-being is flooded with products that are not evidence-based. So we have quite a large evidence base for the Be Well at Work program, which we'll tell you a little bit about. It's effective and relatively low cost. It's the only intervention program of its kind. Also, thinking about working people and that they need something that's convenient, isn't going to take up a lot of time, but also gives them the sense of privacy, is that the program was developed to include both online components and the care is provided telephonically. We can eventually move this to video, but right now we are really emphasizing telephone-based care. And this is one-on-one care with a counselor. This, again, is not a prepackaged program where you sign on and you answer questions and you're led down some kind of algorithmic pathway. This is care that's tailored for the person, that's following a clinically based protocol. So again, it's designed for working people and to be integrated into workplace. And when I say integrated in the workplace, we mean, for example, in the Worksite health clinics. So we don't mean literally in the workplace anymore because we don't even know what that is, right? With COVID, has changed everything. So the program is focused on the clinical goal of functional improvement by addressing medical, psychological, and work factors that are barriers to effective performance on the job and a sense of well-being on the job. We also developed it so it doesn't replace primary care and other forms of behavioral health care. So when employees are signed up to this program, they could be seeing their primary care doctor, they could be seeing a therapist, they could be seeing a psychiatrist, whomever they go to for additional care. And we try to coordinate that care. So it is not overlapping, but it is coordinated. And again, it's really important to state this, is that when we designed this program, we designed it so it would be adaptable to fit into whatever service system that was available. So what we'll talk about a little bit more is that as a clinic, if you decide to use and provide Be Well at Work care, depending on how you're set up, it could be set up as a reimbursable service through an insurance contract. It could be done as an per employee per month charge on an existing contract, and many other ways. So, but our goal here is not to provide the service, it's to teach you and your staff how to provide Be Well at Work. So I like to use the analogy of Lean Six Sigma. When there was this massive training that goes on, it's sort of like wallpaper. You know, a lot of companies do Six Sigma training, and it's just part of the normal way things are delivered, and that management improves and productivity improves. In this case, we'd like Be Well at Work to be like wallpaper. We want people to learn the methods, we want to support them, and then we'd like to see it used widely. So that's what this is about today. Next slide, please. The Be Well at Work care model is different than, let's say, going to primary care. So for example, if you go to good primary care, you know, you'll get a good assessment of depression. You might be, the doctor might suggest that you try antidepressants, or that you see a therapist. So those kinds of things are happening. And they can be parallel to what's going on in Be Well at Work. So in Be Well at Work, we have trained counselors. So we provide the training to counselors so they could do three things which are at the core. And those include functional assessment of depression and how well people are functioning occupationally. So we use validated, very brief tools that provide us a data-driven approach to care. And it's excellent for communicating to employees where they're having problems, because sometimes they're just not really aware of these issues. We also provide cognitive behavioral therapy, but unlike cognitive behavioral therapy, it's workbook driven. It's really easy to use. We provide workbooks, and the counselor sort of walks the employee through the process of learning new skills to cope with work and to cope with life while they're recovering from depression. And our brand of cognitive behavioral therapy is all work focused. So we get people to identify issues that they're facing in the workplace, and then we try to help them develop new skill sets, capabilities to allow them to cope better. And finally, we help people identify barriers to functioning that have to do with how they're approaching their job, how they're, you know, what are some of the environmental factors. And so, for example, if people are disorganized due to their depression, we help to teach them organizational skills. You know, we might use something like to-do lists, reminders, you know, very, very simple kinds of things to improve some of the problems that they're having. So we know, for example, that disorganization, chaos, lack of energy, and difficulty getting along with others at work. Those are all kinds of things that happen a lot with depression. And we have a whole series of techniques that we can teach people so they can try them out. There's sort of small tweaks in how people approach their jobs that have big payoffs. And these three things come together in a system where we are also providing motivational services, you know, helping people to stay engaged. We provide psychoeducation so they understand what is depression, what are your treatment options. We coordinate the care, as I said, with existing providers. And we also make sure that everybody leaves this short-term program with a self-care plan based on the things that they tried. I will say that what is also really important to stress here is that it's an 8-session program. It happens over like roughly every 2 weeks, 1-hour session. It's done over the phone, as I said. It's one-on-one with a counselor that is assigned to an employee. And the care is not long-term, but it's extremely effective. And so this is the general model. This is very different than the kind of care that's out there right now, but it's very focused on the person and the particular work issues they're having. One more important point is that it's confidential. So we do not go into the workplace. We don't talk to supervisors. We keep this all private so the employee feels confident that they can try to change, make small changes where it's possible, where there's some flexibility in their work and how they approach things to again, to recover and to function more effectively. Next slide, please. So just, I won't belabor this, but we have had the good luck of having several grants, most of which have been federal grants through the National Institutes of Health and the Centers for Disease Control with one grant. We've also done some implementation projects. So we have a pretty good idea how to run Be Well at Work, and a pretty good idea of all the different kinds of workplaces that people are in and what's sort of the range of problems that people experience. And at the same time, we have a lot of experience with logistics, how to roll this out, how to make sure that it can be, seamlessly integrated into an existing system. And so you see that, if, for example, we did a project with Optum, their EAP was trained up, and there were 24 employers, mostly their clients. We did something with the state of Tennessee government employees, the Philadelphia VA. We worked with their employee patients, not who worked for the VA particularly, but had lots of different employers, Lockheed Martin Aeronautics, state government in Maine. And then finally, most recently, we did a project within our own center where we set it up so that there would be reimbursement for the care through our primary payer. So we have quite a lot of experience at this point. And so why I'm here today, why David's here today, is to talk to you about what we think is the next logical stage here. And as I mentioned, nothing would make us happier and feeling like we actually achieved something if through all of these years of hard work of testing and refining and figuring out what works and what doesn't, that we could accelerate the real world use of Be Well at Work. And we would like to engage you in a project. Our plan is to initially seek sponsorship, probably through a pharma company. They have these no strings attached sort of sponsorship arrangements that we have some experience with. And our goal is to work with you. So if we can train up one or two of your clinic personnel, maybe more, to provide Be Well at Work and to provide you the support you need to get going, with the hope that you'll continue to provide it, that you'll find that it is effective and it is something that your clients like. And that we can keep going with this and institutionalize the program beyond sort of the walls of academic research. So what we would ask you to do is something like this. We would like you to identify, if you're interested, and we're going to have plenty of time for questions and, get your perspective on this at the end here. We would like to work with you. I'm sorry, did somebody? Okay. To identify a few clinic personnel from your sites, from your organizations, who can participate in a virtual training program that David and I will provide, and teach the personnel the Be Well at Work counseling techniques. We would provide clinical supervision, which is weekly or bi-weekly on the phone or on Zoom, discussing cases and solidifying the training and continuing to advance people in their skill set. We have an electronic system, a platform that is used to manage the care. If right now it makes things a little easier to get the program started, in the future you could either integrate it or have your own platform, which is probably the case. But we teach our trainees how to provide the care using this electronic system, so everything is documented and everything can be monitored, and we can evaluate at the end what the outcomes are and what the costs are. We will provide the necessary consultation to support you to get going with Be Well at Work, rolling it out with your customers, implementing it in operations. We have a lot of experience with how to sell the program, market the program to employees and to employers. You will have centralized access to this HIPAA compliant web-based IT system. And the system has two parts. One is called an employee facing part or component, and it's a website where employees can get online and do private depression screening and enroll in the program if they're qualified. It's very brief. And again, it's all data-driven using evidence-based tools. It's very easy to use, and we think helps employees to realize that they are having problems maybe more than they thought. We also have a counselor-facing website. So the counselors who are providing the care have data about that particular employee from the screening and then can provide the care on a biweekly basis. The idea for the project is that we will have a year one in which we will do the training of your, if you're interested, of your personnel. It could be 2 or more, but we have a maximum of sort of 10 trainees per group at once. And in year one, it would be a pilot year where we would train up, support the implementation. We are trying to get sponsorship for this, but I will show you some of the nuts and bolts of the costs. In year two, what we'd like to do is to have you commit to continuing the program at least for a year. It will be a licensed program because there's intellectual property involved, and we would provide a heavily discounted license rate, make available refresher training, and even train the trainer work. So if you have someone who you think could become a clinical supervisor, we would have a training program for them as well. To the degree possible, we will try to get this sponsored, but we also, have a fairly low cost approach to this whole thing that I'll show you in just a second. Next slide, please. So there's certain costs we would ask you to cover, even if this is sponsored. Obviously, you'll need to identify and provide release time to a couple of people. Typically, we would ask for people with some behavioral health or counseling training. Master's level works best. It's possible to work with nurses if they have some background with cognitive behavioral therapy, but someone who has sort of some degree of mental health training. They do not have to have a doctorate, although we have had counselors who have doctorates in psychology and other areas. But most of our counselors have EAP backgrounds, and they have a master's in social work or a master's in counseling. So you would need to identify people. You would have to provide them with release time so they could get trained up and supervised. There would obviously be some cost of implementing Be Well at Work in your clinics, whatever it takes to provide the service. There would be some probably cost for marketing and communications, and we could provide some backup on that, and other kinds of supplemental, costs that may go out, may be involved in the rollout, excuse me. So one of the things that I hope is attractive is that any organization, any clinic that participates in this is still free to recover the costs through your own payment mechanisms. And as I said, we've done it through reimbursement. I know that may not be available to all of you. It could be added as an additional service under an existing contract, sort of a per employee per month. I'm not sure how you do it. All the clinics, I think, are a little different. We have talked to Harness, for example, and they have the ability to reimburse because I think they're part of the healthcare system, but that may not be the case. But we, again, can work with you to figure out what's a way that you can recover costs, what's the documentation that you need. So again, our goal here is to get the training out, to get people using Be Well at Work, because we know it's a good tool, we know it's effective, and we know it will be attractive to employers. Many employers know who we are. We have a good reputation in the world of work. We've been around for a long time, and I think this is going to be something that is viewed as a high quality product that we would like to work with you to be the early adopters. Post-pilot, we'd ask you to do a minimum year of licensed implementation at your sites, again, with cost recovery. If you're choosing, if possible, we would get sponsorship for the license. But we'll have to see how that goes. So here we're saying seek sponsorship from internal sources or self-fund. Our goal is to seek sponsorship, and we would like to work with Larry so that the association is the hub, is sort of the coordinating hub. It's possible, it may make sense for them to house the platform, so the access might be through the National Association. There's lots of, things that we will have to think about and figure out what the costs are, and then to go make a request to a sponsor. Next slide, please. So If you were to come to us outside of a sponsored arrangement, I thought it would be helpful to see what the charges are, because we've really worked hard to keep these very low. Again, because the goal here is dissemination, and we've had support for many years from national and local funding agencies. So we have an ethical obligation to give back. So the basic training for a Be Well at Work counselor, again, a master's level nurse practitioner, PhD, is $1,200 per trainee. And that is roughly a 2.5 day, it gets stretched out a little bit, but a 2.5 day virtual training. And then we do online video supervision for 6 months, 1 hour supervision, usually weekly or bi-weekly, depending on the caseload. We can provide external support beyond that on a consulting rate, and we use a reduced rate of $200 an hour. Again, there is the potential for billing recovery, and we'll come back to this in a minute because I'm not sure this is going to be relevant here to you, but roughly, we have done the math on, what's the typical caseload for a counselor, and a full-time equivalent is can handle 150 cases per year at about $100 per visit, an average of 7 visits per patient. Is a cost recovery about $105,000, but David is really the expert on that, and we'll come back to that. The license fees we haven't determined yet, but we know sort of what the range of things are out there, and we're determined to really have a heavily discounted license fee in exchange for helping us to get this program out there. Next slide, please. And so I will just end there and say thank you very much. This is how you can contact us. We'd be very happy to meet with you individually if you have questions, but why don't we just, I'm going to just open it up to David briefly for any closing comments, and then open it up for discussion.
I actually think it's better for us to hear questions and respond to you. You covered the territory. The whole issue obviously is sustainability. With any program, it's sustainability. And so it's critically important that we have a year to think about what if it works for your groups, how it can be sustainable. And there, as Deborah said, there are really 2 ways. Thanks to the pandemic, telehealth is here to stay, whether it be Zoom. In many states, actually, telephonic behavioral health is reimbursable, but this is likely to go to a Zoom product for about half of the people, because that's what they like. The other half like telephone, and it comes close to being break even with the way insurers reimburse for master's level services. So why don't we open it up to questions, take off the slideshow.
Great. So let me just go around the table and ask everyone if they wanted to comment. I'll do one at a time. So Kelly, Wilhelm, Kelly, if you have comments, questions about this, let me know. Kelly, can you hear me okay?
Can you hear me now?
Oh, yeah, go ahead. It's
Oh,
great.
sorry. Thank you for the presentation. And it did give us a lot to think about going forward. So something to, consider.
Well, you run a number of mobile units for employers. So let me ask, do you offer behavioral health training right now? Do you have people who do this on your behalf?
We do. We sub it out.
You sub it out. So that you don't have your personnel do it. You have someone that you bring into a unit. Do you do it on an employer's request, or is this part of your core services?
It's part of our services. We actually have a behavioral health specialist that's at some of our sites like 3 days a week. So they're there all day, 3 days a week.
Okay. Is this something that you think would fit in with? Would you have to go to the subcontractor to?
I'd have to go to the
that?
powers above to see if they something they would want to, have one of our current practitioners take part in or something.
Okay, fine.
One of the things
Deborah?
that I didn't, that makes it sometimes very attractive to the behavioral health world is, first of all, it's very easy to use. But I didn't go through this very much, but one of the things about Be Well at Work, it has a excellent ROI. So one of the things that it does, in addition to helping people to function more effectively and recover their mental health and their ability to perform at work, is that overall in the company, when it is offered and used, it has a very large impact on reducing absenteeism and reducing presenteeism. So one of the things that has made it very attractive, and the reason we've been able to onboard so many employers into these studies, is that the effects aren't just at the individual level; they're quite compelling at the company level. So employers that are looking at the sort of post-COVID world where mental health problems have gone through the roof, and I think they've always been there, but now they're even worse, I guess. And people are being very cautious about what kind of services they use because the whole world has changed right now. That the employers are scrambling, to find something that employees are going to use and they're going to like, and that also is going to work for them. And so this is what an unusual situation to sort of get away from the, one size fits all app or the one size fits all online program, and really give people personalized care that is going to meet them where they are. So I do think that's a really important selling point to the behavioral health providers, because they want to be effective. And this gets them away from sort of just saying to people, well, we can give you antidepressants, or why don't you see a therapist or something like that. This is short term, gets right to the point, and again, is personalized. So.
Right, and from a CFO point of view in a company, which is what they mostly and firstly look at, the ROI is somewhere between 3 and 6 to 1. So for every counseled depressed person, that means a company is saving anywhere from $3,000 to $6,000 every year on what was happening, because the average depressed person misses somewhere between 12 and 24 days a year at work, and that their effectiveness at work is significantly reduced. And both of those are decreased. You saw it vary depending on how many comorbid and how sick the population is, from anywhere from 25 to 50% reduction.
Great, thank you. Brandon from Harness Health Partners, comments and questions?
Yeah, I apologize. I missed the beginning, but I think I understand the model. I guess I was curious, have you noticed, are there particular industries in which this works well, or particular industries in which it doesn't work well?
So the most challenging, I would say the most challenging place that we've worked was with state government, because state governments have every type of occupation that there is, and you can get people who are, for example, snowplow operators for states, right? And so when are they going to get care? So the focus on telephonic care has helped us a lot, because almost everybody has a mobile phone, right? And they can do the care over the phone. So what we've had to learn over the years is that it is really not any specific industry. If you look across industries in the United States, no matter what company, no matter what industry, the rate of depression is about 6 to 7% of the population on any day of the week. And that's, we used to think, the rates are somewhat higher among women. So if it's a heavily, gendered role or something like that, it might be a little bit higher. But really, there is no sort of rhyme or reason, epidemiologically, that one industry is worse than the other. We have had people in all kinds of industries and all kinds of jobs. And the result that you see today of having a telephonic program and an online access to a screener and sort of the entire approach was based on the fact that, there's huge variability in what people do for a living, and that we have to meet them where they are. And so the good news is that it works well at all levels. We actually have an ongoing project right now that's looking particularly at low-wage workers in the healthcare industry. And so, you know, David and I obviously have experience in the healthcare industry too. So, you know, that's something that, you know, whenever you go into a particular industry that is defined by a limited series of occupations like healthcare, you know, hospital-based healthcare, you do have to learn quickly about what those occupations are and what the needs of the employees are, but it doesn't really vary much by industry.
Yeah, I think the two major things to consider is that the large majority of people with depression never let anybody know, and therefore they don't get help. And so this is a way of increasing the odds that somebody knows and somebody will get help. And but obviously not everybody is interested in this and won't sign up. And the major logistical thing that's important for providers to understand is, I would say about 2/3 of the people who we've treated over the years, which is now, you know, like 1,000+ people, is they like to be seen between 4 p.m. and 8 p.m. And the only thing we require is if they're on the phone in their car that they are not driving, right? But they can do this anywhere, but the majority of people like to be seen in the later afternoon or early evening. And we've had to adjust our counselor schedules to take that reality into account. Because this is sort of the customer is always right in terms of trying to get them engaged. About 90% of people who actually start go on to have a minimum of 5 visits. There's a total of 8. And the results don't matter very much in terms of outcomes, in terms of absenteeism and presenteeism, whether they have 5, 6, 7, or 8 visits. What we do find is about 10% of people don't know how to say no except by saying yes. And so they enroll and then we can never get a hold of them. So if we can get a person into a number 2 session, then it's likely they're going to benefit from it.
Excellent, thank you. I'm on an unrelated note, I'm curious if you have much experience kind of working with an existing EAP and how you might sell, so to speak.
Yes, so that's our biggest experience, actually. And so as I mentioned, I'm not sure you were on, but we had a federally funded study that went on for, I don't know, 3 to 4 years, in which unusually we hired Optum to work for us. So the Optum EAP was the group that we trained up. We trained up, I don't know, maybe 10 or 15 of their counselors across the country to use Be Well at Work. And so again, it became just another arrow in their quiver. You know, there's lots of things that they provide, but they had Be Well at Work specialists built into the EAP. And we enrolled 24 companies. And so we worked very heavily with their EAP. But almost every project, when we originally envisioned Be Well at Work, it was designed as an EAP project. So EAPs have obviously changed in the 15 years that we've been doing this work. But the main thing now that I think we see with EAPs is that, you know, they are really interested in showing outcomes, right? They get blasted all the time for not having evidence of outcomes or not using standardized measures and so on. And they get called upon to do everything from providing dry cleaning services to providing higher level treatment. And so as a result, you know, their utilization rates, as you know, are not great. And so the more that they can upskill, I think the better. I think many EAPs today are sort of tired of the de-skilling that happened. And that happened over a period of years where everyone said, you know, we just have to have an EAP, and nobody uses it, but let's have it anyway. And over the years, they've had to be all things to all people just in case, you know, to keep their utilization up. But now we see EAPs very interested in upskilling. So they become the experts again on the workplace, and they actually have techniques that allow them to be more effective. And, you know, one of the nice things about this program, we think, is that it delivers the evidence. So it's constantly collecting outcomes data. So a client can then go, you know, an EAP can go right back to the client and say, this is what our effect was. This is what we saved you in absenteeism and presenteeism. This is how many people got better, and so on. So I think the receptivity to EAPs is going to be there. It's not going to be all EAPs. Some EAPs are not interested, they're not participating at that higher level of care. They're, more of the sort of basic EAP. So I think this is going to be attractive to EAPs that want to address the behavioral health needs of their working populations.
Yeah, the major issue, as Deborah indicated, is that the EAP utilization rate is down around 3 to 5%. And that's both the good news and the bad news, because the razor edge of what they get per member per month doesn't allow them to provide everything that they would like to or could, so they would be buried. But the biggest problem, so we've done with 3 different EAP groups, the biggest problem is that the employee workforce doesn't access them. And so this is a way around the access problem. The second problem is that when EAPs stop actually being on site, EAP counselors no longer understand workplace issues. They're not anymore really trained. They're more screeners and referral and short-term sort of problem-solving work, but they don't really understand what employees are struggling with in the workplace. And so again, in the wallpaper model, we add that back in, even if they are no longer there, because the questionnaires both invite and require the counselor, be it an EAP counselor or not, to actually ask the person what it is that they do from the time they get in the morning to the time they go at night, to demonstrate to them what they're having trouble in 4 different kinds of areas, like time management, interpersonal functioning, their output, their physical work, which when people are depressed, their physical scores interfere with their work and they go down as they get better. So there's a lot of advantages. It's just a question of how it gets marketed to the customer. Now, who's the customer? The insurer, the employer, the individual employee, and we have a lot of experience to working with that. So long-winded answer to your question.
Yeah, and the EAP counselors love this training, love it, because it takes them seriously again. So
That's excellent. Thank you so much.
Deborah, would you go over a little bit again the time that it takes for a clinical person to be trained in this ability? And I think you mentioned 2.5 hours, but why don't you go through that a little more?
It's all now telephonic and Zoom and web, but it's probably about a 16-hour program, sometimes a little more, spread out over a couple of weeks so people can digest things and practice some things on their own.
And then we do supervision. So they learn a lot through the training, but then, when they go out to practice, obviously, they're still learning and still developing skills. So usually we get on the phone with, we have a set time for a supervision, and David and I will typically be on the phone. We will be going over cases with them and using that as an opportunity to continue to develop their skills. We send them supplemental information. I think we're a little bit different than a lot, I'll go back to the EAP model again, because it's the easiest one for us to talk about. We have a very detailed protocolized manual. So the manual sits on the platform so they can access it. There's a tools and tips section that allows them to see for any kind of work issue that an employee is experiencing, what are some of the solutions. So it is all guided intervention in a number of ways. So we try to develop a system so that the counselors aren't winging it. That's what we don't want to happen. We want to have high quality care that's following a protocol, but has enough flexibility to be tailored to the person, within reason. So the initial training is really important, but it's only part of the support that we continue to give over time.
Yeah, Larry, one other thing I'd like to add. This is really learn by doing. So, it's like sending someone to a seminar, and it's clear that you got to learn how to use the web and all, the website and all, but But really, once you're doing it and seeing how the electronic record guides you through by asking you questions and documenting things, how to do this in an efficient and effective way, but not in a cookbook way. So, you know, some people really respond more to behavioral kinds of experiments that they have to do. Other people are more stuck on their thought loops, and it's very flexible about how we do that.
Great, thank you. Also, from the NAWHC perspective, what is the platform we would host then moving forward?
So you guys are done.
So we have a website platform, okay, that, as I said, it has sort of an outward facing one that employees can get on, where that would tell them about what this is and ask them to be involved in a screener. And then the more involved clinical management platform, which only the counselors can use. So the question is where to house that. I mean, it's obviously housed on the internet. The question is, you know, would it be better, for example, for us to have a URL that is through the association that gets them into the website? So for example, they might see that this is sponsored by the association, or some way that there's a face page that explains what this is. In terms of the management of the website, we would do that because it's, you know, very involved, technical, you know, and we have people who sort of do all the programming and make sure the website is running. What we might do is set up the platform in a way that each participating organization has their own URL. So they would enter the website, everybody would enter the website through a centralized place, but the URL would take them, let's say, for example, to the harness location. And that harness location could be customized, you know, to a certain face page that employees would see and a certain face page that their counselors would see. So it's possible to modify the platform to be organization specific, but all of that, you know, identifying what the organization needs. Let's say, I'll use harness as an example, but let's say what harness might want employees to see who are using this, or what they want their counselors to see. Larry, you might be the interface, the liaison on those things, and then we would provide the backup to do that kind of modification.
Great, okay. Well, that's good. Thank you very much. Before we close, let's just see if there's any other questions. Brandon, again, any last minute questions or comments? If not, Kelly. Okay, Kelly, any again, last minute questions or comments? Okay, well, what we're going to do, this has been recorded. We will be sending a copy of the recording to everybody else who had registered and expressed interest to us, but couldn't be on the call today. So David and Deborah, thank you very much for your involvement, for working with NAWHC. And we'll be circle around back to you as we get more details from some other people and try to get this rolling. Is there any particular time, a starting time, Deborah, or could we do this at any time an individual wants?
It could be started at any time. I think the next step, though, is if we're going to seek sponsorship, you know, we need to go in as a cohesive group, you know, saying what our plan is and how much it's going to cost, and, you know, seek sponsorship that way. But, you know, that if that could happen sort of over the summer, early fall, you know, then we could move into the proposal phase. And, you know, usually a good time to get a proposal into a sponsor is sometime in the fall. Earlier the better. Okay.
Okay. Well, thank you very much. Thank you for,
Thank you.
for those who are
Okay,
on the
thank
call
you.
as well. And have a good summer. Bye-bye.